Thank you very much. I will just
set up the
share
screen.
the screen.
Good.
So this should load up. Okay, now you should see the screen quite nicely, yeah?
Yeah, that's very good.
Yeah. Okay.
Right. Okay. Well, good evening, everybody, and welcome to Chapelton in central Scotland. Beautiful sunny day here. Sun's going down now, though, but a very warm welcome to everybody, and thank you very much indeed. It's a tremendous pleasure to be able to talk to the West of Scotland Rotary Club. A real privilege. Thank you very much indeed for inviting us along. And what we're going to do over the next 30 minutes is really give you an overview of global healthcare and the challenges and rewards of working in lower middle income countries. We're very much involved in this sort of work, and our work is predominantly in Malawi and Zambia. And we're going to show you some examples of what we do. As I say, talk about the challenges, but also talk about patients, you know, what we do on a day-to-day basis when we're over there. I would give you a warning that we have put in a lot of pictures from the work we do, the patients we see, and some of them are actually quite difficult to look at. They, you know, they are upsetting pictures, but we felt if we're doing this presentation, you know, we really need to show you the kind of work that we are doing, and that, you know, the kind of patients that we see coming in on a regular basis. And for those of you who've got any healthcare involvement over here, really you'll see that this is an extreme of pathology that we're dealing with in Africa due to the underlying poverty, malnutrition, and lack of resources. So what I'll do is I'll kick off and do the first half of the presentation, and then I'll hand over to Alberto, and then perhaps we could have some questions at the end. Global health is very much centre stage internationally at the moment, with the, you know, lack of equity of healthcare, and you just have to turn on the news and you see that all of the problems India, the horrendous problems India is having with lack of oxygen, lack of resources, and totally overwhelmed by the pandemic. And the COVID-19 pandemic has really put global healthcare under the spotlight. It really is centre stage internationally at the moment. And, you know, on the left-hand side of the screen are some of the pictures that maybe some of you have seen similar pictures on the news. But on the right-hand side of the screen, I've included a picture that we took about 18 months, 20 months ago in Malawi. These are children, they're not in a hospital, but they're in an orphanage. And the reason that I've included this on this slide is because they really demonstrate this lack of equity of healthcare throughout the world. These children are all orphaned because their mothers died in childbirth. And one of the indicators, international indicators of the how robust a healthcare system is to look at the maternal mortality and the infant mortality. And the numbers there from 2017 for the ratio of maternal mortality, according to World Bank data, is that there were in 2017 349 maternal deaths in Malawi, compared to 7 in the UK. So, you know, there's more than, well, in the region of 50 times the level of maternal mortality. And that just gives you an indication of the level of healthcare, or lack thereof, that, you know, much of the underdeveloped world is having to deal with. Now, the main organisation that we actually work for is called WOC, which stands for World Orthopaedic Concern. And World Orthopaedic Concern is an organisation, a charitable organisation that provides training and support in trauma and orthopaedics throughout the developing world. And what we've done is we've listed the countries that WOC is currently involved in, a number of which we have visited and been involved in besides Malawi and Zambia. And this list is extending, and I think we're about to add Somaliland to the list. On the bottom of the slide, you'll see the organisations Feet First and FlySpec, and these are organisations which do a very similar sort of work, charitable work, undertaking travelling surgical camps, looking after patients with congenital deformity, neglected trauma, patients with really chronic advanced infection, of whom there are many in the underdeveloped world, and you know, providing reconstructive plastic surgery or orthopaedic surgery. And these organizations are affiliated with WOC. So this is really very much part of what we're talking about and the work we're involved in. One of the really the main focuses of working in the underdeveloped world is not only to go and provide relief, but also to bring education to these areas. And when we do go over, we make sure that education is a huge part of what we do. And that education may take different formats. It may be teaching surgical techniques. It may be teaching using simulation type teaching at a very basic level. It may be what we call moulage or scenario teaching, around the bed teaching, and we have medical students or volunteers who are made up to be the patient, and we put people through the paces and the ABCs of how to manage, for instance, major trauma or pediatric, severe pediatric illness. And we also have a lot of ad hoc classroom teaching, and the bottom left picture is actually in Mazimba, central Malawi, just before theatre lists and at lunchtime, lunch breaks, just teaching about major trauma. The hospital was so keen to have teaching because teaching is such a rarity in many places, in the majority of institutions throughout the developed world. They consider it a great privilege to have teaching and are very, very keen to attend. And this bottom right picture is Dr. Goran Jovic, who's the only plastic surgeon who works in Zambia, and he's teaching some of the local doctors how to repair cleft lips and palps. So education is a huge part of working in the underdeveloped world. If you do work and work in one of the lower middle income countries, you really do have to be prepared, and you have to know a little bit about where you're going, where you are, apart from geographically, politically, what's happening, and also what to expect from a personal safety point of view, but also from a what are the challenges from an infrastructure point of view. And in July 2019, we had a big trip organized for Malawi. And at that time, they had just had the elections, and there was a significant amount of civil unrest and rioting. And the day we were meant to fly out, a friend who lives in Malawi phoned us and said, for goodness sake, don't come. There's very significant violence, civil unrest, and it's not safe to be here. So that trip had to be postponed. So really, it's really important to find out all of these kind of factors, including, you know, your own personal health risks. Do you need to take anti-malarials? What's safe to eat? What's safe to drink, etc. So it's hard living, and we're over here all very used to our sort of standard of living and our luxuries. So you really have to sort of brace yourself a little bit and just know what to expect and prepare yourself for that. The infrastructure problems can be quite challenging to deal with. The lack of water, not only from a personal point of view, but also from what you're trying to achieve when you go over there. Obviously, water is so important, you know, across the board. But of course, if you're going to be working in an operating theatre and you have to scrub, and you're seeing large numbers of patients, you really have to have some degree of hygiene, and you have to put in some kind of system to be able to allow you to do what you're going to do. So sanitation and water preparation, and maybe putting into place your own kind of system if you know that there's not going to be any water in the hospital that you're going to be working in. And that is really endemic throughout much of Africa, that really there is no running water, and you have to look at how you get around that. Power, roads, difficulty with traveling. I'll say a little bit more about that in just a moment, but all kinds of challenges that really we just take for granted. They're all in place here. We walk into a room and we switch on the light and we've got instant illumination, we've got heating, we've got hot water. We're used to it all, but of course, you know, if you're in the underdeveloped world, then you know that is really a great luxury, and you have to learn to work your way around it. Now, one of the things that I need to mention, because it's such a big challenge, particularly in Africa, is the high incidence of major trauma. Africa has the highest road traffic accident death in the world. And if you look at this histogram here on the top left, you'll see that Malawi has the dubious honor of being third from the top, with incredibly high incidence of road traffic accidents, which means very, very high levels of major trauma and a very high demand for the patients who are injured to be looked after. And of course, we know that there are major problems and lack of resources. So, you know, that is an ongoing issue. And many of the people who are involved in these accidents are actually very young people who are providers for the family. So there are lots of different reasons as to why there is such a high incidence of trauma in Africa, but difficult roads and a very underdeveloped transport system and vehicles that are really just falling to bits are all part of this problem. And just to give you a little example, you know, these are the typical roads that you are traveling and you're undertaking surgical camps. You have to plan to be able to get from point A to B to C, and most of the roads are, there are short stretches of motorway, but most roads throughout, certainly Central Africa, look like this with numerous potholes. You have to have a really robust, healthy four-wheel drive vehicle and a really experienced driver to be able to spend long hours and drive many miles along these roads. And of course, in the wet season, a lot of these huge potholes just fill up with water, making it really treacherous for traveling. And then, of course, as you can see from the pictures, the vehicles are in such abysmal condition. There's no such thing as an MOT, and because transport is so underdeveloped, people overload vehicles, and all of these things come together to make road travel very, very hazardous indeed. So very challenging. I mentioned, you know, infrastructure problems, and power is a problem when you're working in the underdeveloped world, and a huge number of people, over 1 billion people in underdeveloped countries, work in the dark or without power. And when 6 o'clock comes, or 6:15 in Africa, the sun goes down very, very quickly and lights go out. So again, if you're going to be working, you have to have some kind of strategy or backup system in place. And I've included a couple of little photographs of the Kariba Dam in Zambia, just to show you how things have changed over the decades, partly due to climate change. And in 1980, the Kariba Dam was very full, and hydroelectric power supplied a very significant number of places with electricity. But because of the droughts over the last few years, that is not the case. And so now very large areas of Zambia do what they call load sharing, and there are very, very significant power cuts, maybe for days on end. So again, if you're working out there, you have to be able to deal with this, to improvise. And this top picture on the right here is doctors in Ethiopia operating by iPhone light, and that is really, you know, quite a frequent occurrence, and that's something that we've had to do on a number of occasions, either use torchlight or mobile phone light to operate. Just as an expectation of what we're going to be up with, but again, particularly when we're looking after trauma patients, emergency care facilities, very, very basic, incredibly basic. And the bottom left picture is a kind of resuscitation bay that we're used to being received into if we have to go to hospital in the UK, in Scotland. The pictures above are the kind of reception areas that have no equipment, and usually one clinical officer dealing with mass casualties, or you know, patients who are sick with malaria, or young babies, all received into these sort of very, very minimal, poorly equipped areas. No ambulance service, and patients are normally transported if they have a road traffic accident, break a femur. A local passerby, a well-wisher as they're known, may scoop them up, put them on a bike, or put them in an ox cart, or if they're lucky, in the back of a truck, or even one of these little blue vehicles which are called tuk-tuks, and this one's been customized, so there's a little area in the back for patients. But everything is basically involves ingenuity and being able to figure out how to address the problems that they're faced with on a daily basis. Just a quick word about the hospitals and the bigger hospitals in Africa, and some of these pictures, most of these pictures are actually from Malawi. Maintenance and safety issues really horrendous throughout. We're talking about very, very poorly resourced and very old equipment in most of these hospitals, and zinc oxide hospital tape holds many, many electrical gadgets together, like the operating light that doesn't work that you can see on the top left. It's actually a little tiny office light behind that is used to operate, which is totally inadequate. Anesthetic equipment is 50, 60 years old and is just strapped together with zinc oxide tape to the nth degree. Intimately doesn't work, and the anaesthetist has to just bag the patient. Bare wires and electricity sockets hanging out, bricks to keep beds from collapsing. Really incredibly basic facilities that are really decades old. And you know, in the top right here, you can see the health and safety issue here with this hanging electric cable that Alberto has just scrubbed and is moving from the scrub sink to the operating table and has to sort of limbo underneath these exposed wires. So very, very challenging. Bottom left picture there, I took that picture in Mazimba, and that is one of the local obstetric clinical officers doing a cesarean section. The table is so old, the operation table, it's stuck at knee level. So this poor chap has to bend at about 45 degrees for the hour that it takes to do that operation, or whatever he has to do that, you know, may take longer than that, but he's stuck in that crouched position. So very, very challenging, but you have to be aware, if you're going to work in the underdeveloped world, you have to be aware of what you're going to be up against. For me, I have an interest in pediatrics and pediatric resuscitation, and really a lot of what I saw, or when we do go to Africa, I come up against is very, it's hard to accept, really. The in theatre, when we're undertaking surgery on little babies or children under the age of 5, there is either no resuscitation equipment, or the resuscitation equipment that is used is adult equipment, which of course doesn't work in youngsters, particularly babies. And you can see here there's a stethoscope strapped to the chest. There's no other sort of monitoring. So it's very challenging. And this little baby was born by cesarean section on the bottom right. And there's a tradition that when the child is delivered, it's wrapped up in the mum's colourful chitenga, and it's just put out somewhere on a trolley somewhere with nobody looking after it at all. And if that child needs resuscitation, well, as the anaesthetic clinical officer said to me, basically the babies resuscitate themselves. And what that means is babies really don't get resuscitated who need to be resuscitated. So, you know, it's very hard to deal with, and there is teaching that needs to be done, and we need to try and help with pediatric resuscitation equipment. And I've just put the infant mortality rate up there. For in 2020, it was 3.6 per 1,000 live births in the UK. For Malawi, you know, more than 10 times that. And that does not include a huge number of children who actually don't die, but have hypoxic brain damage and develop severe cerebral palsy. Vast numbers of children, which is really overwhelming, and we see many of them coming to our orthopaedic clinics. As I'm sure you're aware, many people don't have water. 4 million Malawians have no access to clean water. They're reliant on wells, going and drawing water from the well. And 10 million have no access to a decent toilet. And this is an example on the right of some of the toilets in the hospital system that we came up against. On the left is Ruth, one of our trainee doctors, surgeons who came over and spent a few weeks out with us in central Malawi. And it just shows you the little setup for scrubbing with buckets and water that's been collected beforehand. So improvisation. Despite all of that, it's hard, but the rewards are phenomenal. And really, by just utilizing your skills and some very basic skills, including teaching, which is so valuable, you can make a very big difference to people. From a personal point of view, working in Africa, it gives you a huge advantage from being able to see life from a different perspective and knowing that, you know, things don't have to be perfect in life to be happy, and that if there's a problem, you can figure out a solution. There's usually a way around it. It's not a luxury way around it, but you know, you learn to deal with adversity. So you can make a big difference by just utilizing simple skills and simple procedures. So what we're going to do is going to take you on a little virtual tour of the kind of work that we actually do in Zambia with the flying specialist service, which Alberto is going to tell you a little bit more about in just a moment. And this is in Zambia. And just to highlight, Zambia is a huge country. I was trying to get a picture of Scotland superimposed on Zambia. I couldn't find one, so I put Ireland in the bottom here. You'll see the size of Zambia, and Ireland fits into Zambia 11 times. The population is 19 million, and more than half of that population are actually youngsters, they're children. High incidence, 10% of the children are HIV positive, and the life expectancy has improved now. It's now 62 years. When we were over there 20 odd years ago, the life expectancy was more than 10, 15 years less than that. Lusaka is the capital, and 1.75 million people live here. So 56% of the population live in rural areas. And if you're a healthcare worker, you have to take that on board with all the challenges we've mentioned, difficulty with access, difficulty with roads. How do you bring care to the majority of the population who live out in the bush in this huge rural area, in these huge rural areas? Just to put in the picture, in Scotland we have 227 consultant orthopaedic surgeons and something like 70 other trained surgeons. So we've got in the region of 300 trained specialist orthopaedic surgeons in Scotland. In Zambia, for a country of that huge size with 19 million people, only 18 orthopaedic surgeons. And the one plastic surgeon who we'll introduce you to later on in the presentation is Dr. Goran. Most of the care is delivered by clinical officers who are basically people who have come out of school and undertaken a 2-year training in healthcare, and they can then go on and specialize in a particular area. They're not doctors, they're not nurses. And half of the care that is provided throughout Zambia is from faith-based or non-government organizational charitable care. So, having established that there are many challenges to delivering healthcare in underdeveloped countries, we're going to show you how we've applied our solutions to some of these problems. I'm going to, at this point, hand over to Alberto.
So, good evening, everybody. One of the things that was mentioned by Trish is how poor transport is. But not only is it poor, it's expensive. A subsistence farmer in the northwest of Zambia, to get his child to see a doctor in the capital, will expend his life savings for one trip. Life savings for one trip. And then often when they get there, they're told, yes, they need an operation, but you have to come back in 6 months or a year's time, because today we have no anesthetic. So it's incredibly difficult, and therefore this concept of fly-spec became part of the provision of specialist surgery in Zambia. It was set up by this visionary, this chap in the middle, the grey hair, is John Jervis. He had an OBE for his outstanding work in orthopaedics in East and Central Africa. He's a British trained orthopaedic surgeon who is also a private pilot. He became the professor of orthopedics, initially the adjunct professor, then the full professor in Lusaka in the 1970s, and then realized this problem that patients just could not come to the capital. They couldn't afford it. They didn't have the time during the dry season. The farmers couldn't leave just to take one of their 5 children to hospital. They just couldn't afford it, both finance-wise and time-wise. So John set up FlySpec with 1 aircraft in 1982. And he also set up a training program to start training doctors to provide surgery skills in Africa, in Zambia initially. And his concept has sprouted and is now really very much part of sub-Saharan Africa training. And he was involved in setting up the College of East and Central African Surgery, COSEXA. So what he did was he realized that he had to go out to the bush, so to speak, and he set up a system whereby every weekend he would go out to some hospital somewhere that was equipped well enough for him to do basic surgery. So we can take a little example of Chitikoloke. The Chitikoloke is a mission-run hospital. It's run by Northern Ireland Presbyterians, and they've been there for a long time. It's on the bank of the Zambezi, and it's run by David McAdam, who you see on the right-hand side just now. He's a gifted everything man. He can do everything from surgery to anesthetics to fixing the solar panels. What facilities are available are optimized for each visit. And the rule of thumb is, if we can do it locally, we do it locally. We try and teach people locally to do some of the activity we can bring to them. And we plan the post-operative care in a very simple manner. The solutions for surgery are actually very simple solutions that would be recognized by surgeons in the United Kingdom back in the 1950s and 1960s. It's a completely different practice from where I work in the west of Scotland. I work very closely with a plastic surgeon. Most of the pathology we see is incredibly advanced because of neglected care. Patients would have seen the local witch doctor, the local Nyanga, way before they'll see anybody else because it's local and it's affordable. You superimpose that on the effects of malnutrition, and sub-Saharan Africa is about to face another climate disaster, and with that, a famine. And on top of that, everything is neglected. So trauma will appear months after the injury. So in the top right, you see somebody with a broken leg having fallen off a motorbike, and they'll present months later with that bone dead and the wound still open. And we can cure it by using simple techniques, which is what you see in the middle there. The burns are again completely neglected and often treated with old-fashioned and non-successful remedies, putting cow manure on, mud, and various other things. And that causes scars to contract, giving rise to another problem, which I'll talk about later. Pediatric deformity, either congenital or acquired, is completely neglected. And on top of that, you put the HIV burden, the malaria burden with malnutrition, and TB, which is incredibly common. Some of the challenges are very basic. We don't have sharp blades and scalpels or sutures to do the surgery we need to do. So we have to bring that with us. And that means everything's cut down to the most basic stuff because an aircraft can only carry a certain amount of weight. Anything that we deem we can do locally, we will do locally. Now, we don't do complex surgery in terms of, heart transplants or that kind of stuff, but we do stuff that would be complex surgery in the United Kingdom. We do that locally. So there's a child being grafted with chronic burns using a mesher that we bring, and it's a skin graft that's being prepared and being applied. And it's all done low tech, but this will save this child's life. And it's all done with relatively low resources. The Zambian government allocates $4 a year per head of population for continuing healthcare. The typical program we would work normally in the university during the week, and on the Thursday morning, you'd rush a clinic, and at lunchtime, you'd go out to the airfield, and you had your aeroplane pre-packed and ready to go, pre-fueled, and the flight plan already set out, and you'd fly maybe 4 or 5 hours from, for example, Lusaka, where we're based, out to Chitokoloki. You have to get there before 6:30 because it gets dark then, and you can't fly at night with these light aircraft, and there's no electricity to run any kind of runway lights anyway on the dirt airfields. The fascinating thing is, despite the fact there doesn't seem to be anybody there, the moment the aircraft appears, rent a crowd of children, curious. It's a big event, the aeroplane coming from the capital. And then you start the clinic. And this is a clinic. Now, can you imagine what this means in a COVID era? Everybody's on top of each other. You might have 100 patients with their relatives, friends. The mothers might have to bring 3 or 4 children because you have to look after them. So there might be 400 people with 100 patients being seen. And you just work your way through and decide what you're going to do, what resources you have to be able to operate on these patients. You set up a theatre list in conjunction with the team that you're working with, the local anaesthetic officer, the nursing staff, and work out trying to make the most of what you have, but also the best bang for buck. So, for example, children are prioritised and neglected trauma is prioritised. We are now able, it's amazing how mobile communications have changed the world, but we can be called by WhatsApp days before we go out saying, we've got a really complex problem, can you bring such and such a piece of equipment so you can deal with it? And then the patient has a little passbook, which is called the patient passport, and all the instructions are written down so that the local nurses or physiotherapists can follow the ABC guide of rehabilitation and what to do, when to take off the plaster, when to take the stitches out, when to mobilize, and what to do. Some of the problems we face are problems that no longer exist in the United Kingdom. Burns in Africa is a neglected epidemic. When the parents are out working in the fields, one of the young children is going to be cooking the mealie meal over an open fire. And that young child may also be looking after the younger siblings who may just be crawling around and very poorly supervised. If they have malaria and they get a temperature, they can have an epileptic fit and fall into the fire, and accidents happen. If you're fitting and having an epileptic fit, the local tradition is that you're possessed by a devil and you should not be touched, because if you're touching somebody that's having a fit, the devil will jump into your body. So they literally leave that poor person to burn and cook in the fire. And when they stop fitting, then they move them. So the burns are often much more severe than we would ever see in the United Kingdom. And then they're treated badly by the local witch doctor or by the local grandmother, the nana. And this is what happens. These are severe contractures, contracture to the hand, contracture to the elbow, contracture to the armpit, contracture to the neck. So the mouth can't open and this poor child struggles to feed themselves. If we do something well, this is what happens to the child. The child goes back to having a face that they can close their mouth and masticate. They can look straight ahead. They can use their elbow. They can use their hand, and they can use their armpit. They can return to some form of functional normality. So we have to ask ourselves, it's a huge effort. We spend about £300,000 a year providing this service in Malawi, in Zambia. We provide another £60,000 to £70,000 worth of work in Malawi, northern Malawi. And it's a lot of money. And we are asked several times by donors, by people in churches, is it worth it? Is this effort worth what we do? Well, you tell me. This is a condition called NOMA. Many of you will remember Boy David, who was treated by Ian Jackson, who is a plastic surgeon initially at Canisburn, who now works at the Mayo Clinic. Boy David was one patient. Goran, my plastic surgery colleague, will have 15 or 20 of these patients in his clinic. And noma is basically a gangrene caused by malnutrition and malaria and just being on the back curve the whole time with poor hygiene. And it basically eats away your face. You can't eat, you can't swallow, and you basically die of starvation. By treating them, we can feed them, and we can correct all of that and return that child to life, a normal life. Some of the burns are quite dramatic and they're destructive. So literally the arm may have been lost to the burn, but by providing good plastic surgery and covering the skin, we can then provide ability to put a prosthetic on and return to some kind of life. And look at this child here who couldn't actually feed themselves because their hand and the elbow is fused to their face. Now is happy because he's got an arm that he can use, and he can use this as a stopper with a good stump in the right and in the left. And we can actually do something later to provide some kind of function as well. The cleft lip and palate surgery that Goran Jovic, a plastic surgeon that originally came from Serbia, he ran away during the Civil War because he was going to get shot in Yugoslavia, ended up in Africa, great gain for Africa. When I first worked in Africa in the 1980s, if you were a girl and you were born with a cleft lip or palate, you were often just wrapped up and left to die as a newborn because you had no value as a wife, a future wife, because you didn't look right. And now, with effective plastic surgery, we can convert children to normality. And people now know that this is the case, and the children do come to have surgery. It's just difficult to provide it quickly. These are some of the burns patients, other examples of terrible contractures. You know, obviously this child has now had their contractures dealt with. This child here doesn't really have functional fingers. Basic plastic surgery will recreate the basic ability to oppose the thumb and forefinger, and it changes that child's life forever. Club feet, very common in Africa. If they're neglected, the feet will ulcerate and eventually lead to limb loss. And obviously it's difficult to function like this. If we get them early, we can manipulate them. If we get them later, we can do surgery to correct the deformity. And this allows the child to go to school, work, socialize, and have really a normal life. So this surgery is life-changing surgery. If you're a farmer, a subsistence farmer, and you have 20 people relying on you working in the fields, and you sustain a fracture falling off your bike, or a fracture falling off your ox cart, you will not work for 2, 3, 4, 6 months if the fracture heals. If the fracture doesn't heal, your family will starve. So again, bringing fracture management, which is simple fracture management, it can be external fixators or simple nailing, we can return somebody to work in 8 to 12 weeks. Because we know that neglected fractures cause loss of livelihood in young males, who are the ones that tend to have these fractures from road traffic accidents and other work accidents, and as you saw on the roads. And this is somebody who's having his nailing done. This was done, he actually had it done 2 days after the injury because we knew that the type of fracture he had was never going to heal. And this is him a year later. Clearly, he's now working and an incredibly happy teddy bear. The challenges are getting more difficult. Africa is going through a second drought, and with that comes famine. The effect of COVID on the economy, which is mainly tourist-based and is very much hand-to-mouth living, has been significant, and the governments are suffering. It's one of the problems we're now facing, and we're planning some of our visits in June, is that we have to provide food for the patients and food for the staff, because the government often is unable to pay the staff and the hospitals to buy food for the patients. In 2019, before the COVID pandemic, we carried out 1,112 patient operations, and we saw over 4,000 patients in our fly-spec visits. On top of that, we saw patients obviously at University Teaching Hospital and in 2 or 3 charitable hospitals that operate in Lusaka and in Ndola. And that is with a relatively small budget. It works out at about $120 an operation. So this surgery using aircraft, and Goran is a pilot, I'm a pilot, we fly ourselves to these trips, allows people to return to being independent and work and support their families, complete an education and have a future. So the question is it worth it? Well, I think so. These patients think so. And he's hoping it will be worth it. Thank you very much.
Good.
And if you've got any questions for us.
Yes, I'm quite sure we all have. So I've got some, but I'm going to put it out to the floor when we use that expression. So, right, who's going to put their hand up first, please? Right, Claudia, thank you.
Hi, that was a fantastic talk.
Muted.
Sorry, sorry, Claudia.
No, that's fine. Sorry, am I muted? You're muted.
We can hear you now,
We can hear
Claudia.
you.
Fantastic. Sorry, I just wanted to say that was an absolutely fantastic talk, and it was amazing to see all the work that you do. Also, I'd spent 6 months in Malawi teaching in a school, and it was just wonderful to see pictures of it again and all that. It was wonderful. I had a few questions, but one of my questions was, you said that a lot of the hospitals were faith-based. Do you find that poses problems for, I don't know, young unmarried people? Do you find that things like superstition and religion are quite detrimental to your progress?
Just to address that, yes and no. To some degree, the CHAM hospitals have better funding and frequently better facilities than the government hospitals, so they are at an advantage. Throughout Malawi, many people throughout Malawi, and I'm sure you experience this yourself, are actually very religious anyway, and even in some of the non-faith-based hospitals, when you go to the to the outpatient department or you're on the wards, you'll see a lot of patients singing and praying together. But yes, there is certainly a theme which is much stronger throughout the CHAM or the church. It's the Church
Hospitals Association of Malawi.
Yeah, the Church Hospital Association of Malawi. So yes, there is a significant religious thread that goes through that, but many of the population are very religious and are actually very although they use the witch doctor, it's a bit of a paradox for healthcare, particularly those who can't access hospitals. They still actually have this faith, and if you go to church on a Sunday in Malawi, and I'm sure you remember this, there's standing room only in the churches. So religion is huge for the people of Malawi. But yes, in the faith-based government organization, there is often a stronger thread of that, but it's ubiquitous probably throughout Malawi.
The other thing, there is an acceptance of people perhaps not behaving in the way that some of the more religiously minded people would think. So there's no denial of access to healthcare in the faith-based hospitals, and we've never come across that. But it's quite interesting, sometimes people do jump to conclusions. And I always remember a multiply injured patient in University Hospital who had been stealing a food tuck and got caught. And basically the bystanders pummeled this poor man to literally an inch of his life. He was brought into hospital, and the nurses said, "But he's a thief, why would you bother with him?" And it was an eye-opener in many ways. And then when we actually said, no, but at the end of the day, he's another fellow human being, they just rolled their sleeves up and just got on with it. But there is sometimes a little bit of it is a paradox of care, but I've never seen, for example, in Muslim-based hospitals, denial of any care to anybody who doesn't follow the faith. For example, if you're drunk and you come in and you've injured yourself, or if you're an unmarried mother, you won't be denied care. Some people will, however, judge you. but the care isn't denied. So again, there's this sort of dual track, which is quite off-putting when you're brought up in a Western-based system of values.
Okay, thank you.
Thank you very much indeed.
I had one more question. Is that
sorry, Claudia, on you go.
Well, I just wanted to ask, so when I was there, I was actually in the capital when the voting happened, when and actually I was there 11 years ago, and it was honestly one of the most peaceful places ever, and I felt so safe being in the city, and people were, you know, the children were really they're really keen to talk about it in the school, and I know that everybody wore their kind of, they signed their ballot paper with their thumb, and I remember they all kind of wore that as a badge of honour, like I've voted, I've played my part. But it's interesting to hear that it's changed so much in the last 10 years that it's now.
Well, it hasn't, it's changed and it's not changed. There was an attempt essentially to pervert the course of the voting by President Mutharika.
It was referred to as the Tipex election.
The Tipex election, where the voting papers were in large numbers were changed. But whilst there was demonstrations and a sustained campaign, which culminated in July, basically, the thing went to the High Court. What was amazing was the High Court system worked and ordered a rerun of the election. So that those demonstrations that we showed pictures of, people were relatively peaceful, but the army and the police, as far as the government were concerned, tried to suppress them. And that's where the violence occurred, which was quite difficult. But the people were getting frustrated, and most of the violence that was reported was at the end of a long day of demonstrating, people drinking too much beer. So it's a bit like, you know, celebrating Rangers winning the winning the.
As you say, Claudia, the people of Malawi are, as you know, referred to as the warm heart of Africa. They are lovely, peaceful, just very happy, full of joie de vivre type people. So it was an unusual situation. Yeah.
Mm-hmm. Okay. Well, thank you very much for that, and thank you for answering my question.
Right. Can I ask one just now? Do you both work full time for the charity, for WOC UK? Is that your?
So WOC UK is an NGO, a registered charity. Everybody who works for WOC UK is volunteering. There's nobody paid anything for doing anything. And it's WOC UK is the first World Orthopaedic Concern charity set up as a sort of grandfather charity for World Orthopaedics. And basically, I'm chair-elect of World Orthopaedic Concern UK, and basically we work with that as an umbrella organisation. But we do work, what we do is we support people in whatever way they ask for support. So many countries will come to us and say, we need help in teaching. We're developing, but we need help in teaching. Can you help us in teaching? So in Somaliland, that's one of the recent requests. In Ethiopia, we've been teaching in Ethiopia, and I've set up the Ethiopian orthopaedic training programs since the 1990s. In Ethiopia, there were 7 orthopedic surgeons for 60 million people. We've now trained 400, and we have all these independent training programs throughout Ethiopia. So in many countries, it's education. In Malawi, northern Malawi, it's service provision. So we actually go and operate. In Zambia, it started off as service provision, but because of the education, we have now 18 surgeons in the country. Because we've trained them and they work with John Jellis, we actually used to take them out in the fly-spec trips. So many of the fly-spec trips now are actually run by Zambians for Zambians. And the effect of that is, during the COVID pandemic, 85% of our trips in Zambia have continued, whereas in northern Malawi, nothing has happened as far as orthopedic care is concerned in northern Malawi since the end of March, when we were evacuated last year. So we work for them, but we give our time free. And then the other thing is most people are self-funding, because most of us are either retired or towards the end of our orthopedic or medical career, and we have to give something back. We all feel we have to give something back.
Thank you. Well, the reason I asked that, you're a charity, yes. I mean, have you given many talks to Rotary in UK?
Two.
Yeah, I think it's 2, possibly 3. So a few, not many. You know, we do teach and we give talks, and one of the things that's become apparent is that the junior doctors coming through are incredibly keen to be involved in global health, which is really quite a big shift. But yes, we have, and we do intend to, as much as we can, you know, let people know about FlySpec and what's happening. And the Rotary clubs and Zoom meetings are probably a good opportunity to do that.
Well, I'll leave this to Ray to connect with you on that one there. But we, in our district, the west of Scotland, we have a speakers list, and we also have one which we have to put on for people for Rotary Great Britain and Ireland. So we would be keen to help you there. Because at the present time, raising funds in Rotary is a very hard thing to actually do, but I think helping you to make an awareness is the least that we can actually do. Rotary, as you know, have things like Shelter Box. We've got Aquabox, and unfortunately Stephanie is not here this evening, and she's one of 5 members from Clean Water Wave. Who you may not have heard from them, but I'm going to certainly send you and introduce you to Stephanie, because you never know, because a lot of Rotary clubs, as our district is involved, are involved in different parts of Malawi, as indeed was it Jack McConnell, Lord McConnell? Yeah. Yes, I think he's been very involved. I think still is involved as far as Scotland is concerned. You mentioned $4 a head. The UK government gives a lot of money. Does it give money to those African countries that you're working with, or does it go out correctly?
That's a very difficult question to answer. So 3 things. First of all, the UK government, for example, has operated out of East Kilbride, in fact, from DFID. And unfortunately, that's now become part of the Foreign Office, the FCO, with a change in direction of aid. And also, as you will be aware, Boris Johnson and Rishi Sunak announced that they were cutting the overseas aid budget.
Yeah.
And this is a time that most definitely we shouldn't be doing that. One of the issues that people will tell you is that a lot of overseas aid is funneled for what I would call self-interest projects. They're projects that have a benefit for the donating country, which isn't always what we really should be doing. For example, the COVID pandemic, there's a lot of aid has gone into dealing with the COVID pandemic, but it hasn't really changed the lot of the person in the street. You know, it's all fine and well putting in all the means for checking people's temperature and doing rapid testing at an airport. But really, a lot of that is to protect the Western world from a strain that's going to come towards them. It's not being... corruption is an issue also that people are trying to deal with, incredibly difficult to deal with. Corruption happens all over the world. As you know from my name, I'm originally Italian, but you know, corruption is just something that happens. I think in Africa it's much more obvious because people are more blatant in how they do it, rather than it's more corrupt or less corrupt. It's more blatant. The smaller NGOs are incredibly effective with what they do. So the smaller NGOs such as CAFOD and Mary's Meals are very effective because they don't have to interact at the higher levels of government and therefore engage in some of the things that are difficult. And the recent pandemic in Malawi, we've actually raised £40,000 despite COVID for an oxygen appeal which everybody told us we couldn't do, and we managed to raise £40,000 and invest that money directly in things that helped. And we actually spent all the money and provided all the equipment within 6 weeks of the appeal closing. So it can be done, but corruption is something you have to be very aware of. And the other side of the coin is, Tricia always tells me never to judge, and she's right, because if you're coming along from a European environment, people will regard you as rich because you've got clothes, you've got a cell phone, and you can come and go as you please into that country. And they are very poor. They may be struggling just to feed their families. So if they can see a way of getting an extra $10, you can afford it. They can't. So that seems it's perfectly normal. It's not regarded as corruption or bribery or theft. It's just making ends meet and surviving.
Survival. And the Scottish government also has projects up until the pandemic last year, has projects in Malawi, Zambia, Rwanda, and there is one in Pakistan. So they have provided major support over the years in various projects to a number of countries in the developing world. So,
are there any more questions, please? Claudia and Ian. Claudia and then Ian.
I just was going to ask, you said there's 349 per 100,000. Is that what you said?
Yes, yeah.
Young mothers who died, and that's why there was such a high rate of there were orphanages. Is that due to the fact that a lot of the mothers are very young mothers? And
yes, I mean there's a huge, I think something in the region of about 20% are teenage, nearly approaching 20% are teenage pregnancies, teenage mothers. But a lot of the problems are this lack of ability to access any kind of obstetric care. And as you saw from the map, so many people live rurally and cannot access any kind of help throughout their pregnancy. And when they do present with obstructed labor or whatever, it's too late to do anything about it. And then, you've got the underlying malnutrition, poverty, no resources, nobody can do a cesarean section. So when you add all of these things together, it just becomes this massive monster of a problem. And the same with the infant mortality rate. But the huge problem you see when you just walk into any clinic and you see this huge number of children with cerebral palsy, which is devastating, huge number, and that's from birth hypoxia. So it's not just the matter of the children who die, it's the children who have this terrible brain injury from lack of obstetric care, basically.
One of the issues in Africa is also very young marriage, which there's been a lot of projects to try and reduce basically childhood marriages. And there's a lot of work done by UNICEF. The Scottish Government funded a big project in Malawi to try and fight child marriages. Very successfully until COVID hit. It's quite interesting. The rate of child marriages has absolutely exploded after the COVID pandemic because the kids couldn't go to school, nobody could work.
Big peak in the birth rate.
So everybody said, well, you're going to have to get married because you can't go to school and you can't find a job. And that's been a problem. And we're now seeing 9 months later the issue with the very young mothers who've had little or no obstetric care.
Thank you. Right, Ian, I'm going to make yours the last question. I'm very conscious of time.
Thank you very much indeed, Alberto, Patricia. One of the things I was going to ask at the start, which you've largely answered, I think, is to do with teaching, and does it work or does it not? I wonder, is it structured teaching where you can see progress being done on a weekly or monthly basis, or is it tend to be teaching on a one-off basis, and then you're not there for 6 months or so?
Yeah, okay. Well, it's the combination of both, actually. And does it work? Yes. And in fact, We have been working in Africa since we retired in 2018, and before we took up our consultant jobs back in 1997, we were actually over in Zambia for 6 months, and we started up a program which is very similar to the trauma management, the ATLS, Advanced Trauma Life Support, which is an American trauma management program, which is phenomenally expensive and very elite, and there's no way it could be transported to Africa. But basically, we took the principles and we ran our Zambian trauma management course, and that has now been adopted and has become part of the Zambian surgical training. So all of the doctors now who become surgeons, any kind of surgeon, that is part of the training. So yes, that has stuck. That's great. The teaching that we have been doing over the past couple of years, we're trying to get it, but we were just beginning to get momentum when the pandemic started. But yes, we do ad hoc teaching everywhere we go, but we're trying to get regular programs going. But obviously we have to be pandemic free to be able to do that. But that's the intention.
And obviously the orthopedic training program in Zambia was set up as part of this back in the 80s, and it's been incredibly successful. So there are structured teaching programs that are in the system. In Malawi, we've been teaching the clinical officers to do the basic operations. And that stuck as well, because these guys can do these operations now, and they know what they can do safely. And what's interesting, they know what they can't do, but they'll keep that for you when you arrive. And then they'll say, can you teach me how to do this one? Which is very interesting, because they see that they can extend themselves. So the teaching does work. Part of the problem about teaching is the environment may not be suitable to then carrying out what you've taught them. So we have to try and support them. And that's one of the things that we need to do. And that's equipment, facilities, being safe. So, for example, we've provided surgical gowns, sutures, swabs, the equipment that are needed in the different hospitals for people to do the surgery safely. So, yeah, the teaching does work, but it'd be nice to have no pandemic and to be able to continue what we did for a while.
Right, so thank you. The vote of thanks is in the name of soon-to-be President-elect, right? Only another short while. Raymond, please. Ray.
Thank you. Alberto, Patricia, all I can say is thank you very much indeed for a very thought-provoking presentation. I think we were all absolutely flabbergasted, because when you see some of the messages that are in the chat right now, and when you see some of the faces, I think what you are doing is absolutely wonderful, and to be honest, really miraculous. And the fact that you are actually paying back, I only wish an awful lot more professional individuals would actually have the same attitude as yourselves about actually paying back to society for what we have earned. Because it's true what you say, I think we take an awful lot for granted, especially here in Scotland and the Western world. And then when you see what you've just presented there, and for what you do and the changes that you bring to those individuals, it's absolutely amazing. I'm absolutely flabbergasted. And I think from a Rotary Club, I think we can wish you all the very best, because I know you're flying out in June soon, to hopefully, and it'll be very safe for you. And I would just like everybody in the usual Rotary way to say thank you very much indeed for an absolutely stunning presentation. So thank you very much indeed.
Thank you very much. An absolute pleasure. Thank you for the opportunity of presenting.
Thank you.
Yeah.
Right, you don't have to go. Right, well, just a little bit to go just now, and we should be finishing shortly. Okay. Date of next meeting, Tuesday the 1st of June. I've got the months right this time. The annual club assembly, when President-elect Joyce will be presenting her plans for 2021-22. So we shall look forward to that, and more importantly, to supporting Joyce. First, can I say thank you all for your attendance this evening, to our speakers, Alberto and Patricia, and indeed to our visiting Rotarians and guests. And if any of our guests would like to learn more about Rotary, let me know, or let another member know. And can I ask our own club members if they could remain behind, please, And in the traditional way, the final toast will be Rotary the world over. So I think